Good afternoon, everybody. Today I'll be presenting a comparison of posterior optic capture, which is a conventional surgery, versus endocapsular implantation in pediatric cataract surgery. Sorry, I cannot see the time here. I cannot see the time.
ये टाइम इधर करा दो भाई.
कोई बात नहीं, हम बता देंगे आपको. अब टाइम क्यों वेस्ट करना?
So I have no financial interest. The surgical aim in pediatric cataract surgery is always to prevent or minimize visual axis obscuration and inflammation to prevent amblyopia. So what is known is that the conventional surgery is always primary posterior capsulotomy, you do an anterior vitrectomy, and an endocapsular intraocular lens implantation. But then there is a 30 to 40% risk of visual axis obscuration, and now we have modifications and improvisations in the form of bag in the lens and anecdotal reports on posterior optic capture. However, there is only one randomized trial comparing optic capture versus IOL implantation in the bag, and I want to stress this point, it has been used in different patients. So only one eye was included at a time. So we wanted to do this study because there was no randomized study in children with bilateral cataract. We wanted to use the same eye so that we are not biased that the eyes would cause inflammation. So we did one surgery in one eye and used the other eye for the other surgery. Long-term sequelae over 1 year are not reported. There's scanty literature with the newer lenses, and we wanted to use a newer lens. So it was a prospective randomized interventional study with children under 5 years with congenital cataract. There was no contraindication for IOL. We did a complete ophthalmic examination, biometry, followed a standard post-op topical regime. The second eye was operated within 2 weeks, and the sample size was calculated with the only studies or the reports available to have a power of 80%. So we had a minimum of at least 13 patients. The surgical technique was, we divided them into 2 groups. It was a single surgeon study. Group 1 included the slightly unconventional surgery, what we do, that is primary posterior capsulotomy and the optic capture. We did not perform an anterior vitrectomy. The group 2 was the conventional surgery. So just to show you what the optic capture is, basically, some of the modifications what we did was, you can see here, this is the posterior capsule. The posterior capsular opening has to be slightly larger, or maybe almost similar like the anterior capsule, because you want the IOL to prolapse behind. And then, through the tunnel, we implanted the IOL. So we used the 3-piece hydrophobic Hoya acrylic IOL. And the first step here is to have a safe implantation in the bag. So once you have a safe implantation in the bag, then it's easy to prolapse the IOL. The important point here is be careful that the haptic does not go right through the posterior capsular opening. So once you dial the IOL in the bag, you will see that one edge of the optic is slightly nudged behind the posterior capsule. You can see here. And now the other side is nudged. So at the end, you see an oval opening. This shows that it has been successfully captured. So this is the posterior capsule with the oblong opening. So there were 32 eyes of 16 children, had to exclude 3 eyes because we could not place the IOL where we desired. So we were left with 13 eyes for analysis, and a majority were less than 7 years. The biometric profile of both the groups was similar. So some of the adventures we had were an escaped anterior capsular axis. Sometimes we had a large posterior capsular axis, although just in one patient in each group. We had a pre-existing posterior capsular defect in one eye, but that did not preclude us from performing an IOL, and we could place the IOL where we intended. So the post-operative adverse events are very important over a period of 2 years. No visual axis opacification in either group. But what was important in red is the inflammatory sequelae, which was significantly more in the eye where the conventional surgery was done. And these patients were mainly less than 1 year. And these are some of the photographs, the post-op photographs what we had. This is the series where we have put the IOL in the bag. So you can see at 3 months, pretty clear. You can see the posterior capsule, the IOL in the bag. And this is the one with the optic capture. The fused capsules are clear, they're trapped cells. And at 1 year, what you see is florid proliferation occurring here. You can see they're almost till the edge, whereas the one with the capture has a clear visual axis, and there's fibrosis along the edge, they're trapped cells, so nothing coming in the center. And at 2 years, the proliferation still increased. You can see some epithelial cells coming onto the vitreous face. But here, it's fibrotic, well fused, and nothing there to come into the visual axis. So I want to conclude here that optic capture is a promising alternative to conventional pediatric cataract surgery. It has significantly less inflammatory response. The bag is sealed. There's no visual obscuration, no proliferation of the lens epithelial cells. There is no risk of geometric decentration because your IOL is fixed with the capsule. And most important, it avoids the ill effects of vitrectomy. We did not perform an anterior vitrectomy in these patients where we did optic capture. But it has a learning curve which can be mastered with time. Thank you.